Добрий день. Давайте перевіримо, чи Фабіана мене чує через перекладачів. Бачу, що Фабіана мене чує. Добрий день всім. Дуже дякуємо, що ви приєднались до нашого сьогоднішнього вебінару. Ви всі знаєте, що це велика серія. Мене звати Катерина Булавінова, я медична експертка ЮНІСЕФ в Україні. І ми організовуємо цю серію разом з Міністерством охорони здоров'я, з Національною службою здоров'я України за підтримки ГО «Ранні пташки» і при підтримці уповноваженої президента Дар'ї Герасимчук. Я дуже дякую Фабіані, яка погодилась сьогодні проводити цей вебінар для нас. Ваші питання, як зазвичай, ставте в коментарях, і ми будемо наприкінці їх задавати. Перекладачі будуть все перекладати, я буду зачитувати запитання і будемо отримувати відповіді стільки, скільки вистачить в нас часу у Фабіани. Тому, щоб його не витрачати, я ще раз всім дякую, що приєднались, і прошу Фабіану починати.
Hi, thank you everyone. Let me just share my slides. So, hello everyone. I'm in Toronto, so good morning and good afternoon to you all in Ukraine. I'm very grateful that you are joining us here today, and I want to thank UNICEF for inviting me to speak and share my personal journey. I will also share how our parent-led organization is working with the healthcare system to support families after discharge from the neonatal intensive care units in the second part of this presentation. So let's begin. Give me 1 second. When you look at this picture, what do you see? Some of you will see the boats and some of you will see a bridge. It's all perspective. Having a baby in a neonatal intensive care unit is also all perspective. And today I will share with you what changed my perspective and how being involved in my son's care through the family integrated care model, as known as FiCare, changed my NICU experience, a journey that I call from surviving to thriving. And this is how it all started. After a long journey of infertility, I had my first son, a healthy term baby. 2 years later, I got pregnant with twins. At first, I was overwhelmed with the news, wondering how I would raise 3 children under the age of 3 in Canada. I am an immigrant, I have no family around. But a few weeks later, I learned that one of our twins had a heart condition and 0 chance to make to birth. At 26 weeks, I went into labor and delivered the twins. Michael was stillborn and Gabriel was rushed into the NICU, which became our home for 146 days. When I first met Gabriel, I did not see a baby. I saw the wires, the monitors, and a plastic bag. I was terrified, barely surviving. The first few days were very foggy. I was in shock and wondering how an entire life could be contained in only 900 grams. I was too scared to ask if he would survive. To make things worse, one doctor told me that Gabriel had a heart condition. I shut down and I stopped listening. I cried and he asked me why I was crying. He certainly had not read my chart saying that my other twin had just died from a heart condition. After that, I wouldn't want to talk to anyone, and I didn't want any updates on my son's condition. His dad was the one receiving and communicating with the medical team and passing the information to me in a smaller doses, what I call the homeopathic doses. And as the days and weeks passed by, the NICU started to become more familiar, and I started to ask some questions that were relevant for that particular day. One nurse, an our bedside nurse, suggested I joined a research study called Family Integrated Care, or FiCare. I was told that if I joined the study, I would be part of the team, I would have peer support, I could attend daily education sessions, and participate in medical rounds. I had no ideas what medical rounds were, but I decided to sign up to the study. And that's when everything started to change and my perspective of the NICU changed. The bedside nurses were instrumental in my journey. They translated the NICU terms into mom's terms. We cried together, we laughed together, and they were always there for me and my family. They really made me feel I was part of their team. They taught me how to parent in that strange environment. I was very involved in Gabriel's care, and I also learned how to recognize his needs. They always said to me, look at him, look how he's breathing, look at his colors. Do not look at the monitors every time I was holding him. I attended daily education sessions. We had sessions with different members of the NICU. For example, with the pharmacist, we even tasted some of the medications. We learned about feeding, the most common conditions, how to support our baby's development in the hospital. We learned the importance of our voice, touch, singing, reading, and how to do tummy time. We also had breastfeeding support, and you can see in this picture on the right-hand side, my freezer at home filled with frozen milk from countless pumping sessions. We also had mental health support, and the CPR course was mandatory for us before discharge. So back in 2012, that's when my son was in the NICU, we still had paper charts. I had my own chart, and every day I not only participated in my son's medical rounds, but I also presented him at rounds with our bedside nurse. And my charts really helped me to do that. And by doing this, I really gained confidence speaking with healthcare providers and learned what questions I should be asking. As part of FiCare, we also had peer-to-peer support by the bedside. It was so important to know that we are not alone. Having parents who had been in our shoes coming back to the hospital was very powerful. They were hope they were longing for on those days. So peer support was truly a lifeline for me during my NICU journey. And it wasn't just about sharing experiences. It was really about feeling seen, understood, and really less alone. And I had peer support in many forms. We had a graduate NICU parent who regularly came by my bedside. This is the lady on the left side of the screen. Her son had been born at 27 weeks, and so she was always coming back to our side, our bedside. We also had weekly sessions for moms only. They were safe spaces where we could speak freely about our fears and how exhausted we were without any judgment. That 1 hour a week became so sacred to me. It was the only time that I could really breathe. Sometimes we cried together, sometimes we laughed, but every time we reminded each other that we are not alone in these circumstances. Peer support truly validates emotions. It helps transform isolation into community. And I truly believe that connection can make all the difference in a parent's mental health and healing. We were also encouraged to be there as a family. So every Sunday, my older son came to the hospital to be with his brother. There was no restrictions with siblings in the NICU. So in this picture here, you can see my son, who was 3 years old at the time, and holding Gabriel. And I have to tell you, 13 years later, he still has this picture by his bedside table. That how important that day was for him to hold his baby brother for the very first time. Well, and it was finally time to go home. In preparation for discharge at a family meeting, our doctor told us that Gabriel was going to be discharged on home oxygen. I cried and I told the doctor that I didn't want to bring the hospital home, that I just wanted my life to go back to normal. With a very kind voice, she said to me, "This will be your new normal." After 146 days, our baby boy got discharged. He did come home on oxygen, and I was afraid of losing the hospital support, but I was reassured that I was prepared to take care of my baby at home. After all, I had spent over 1,100 hours by his bedside, and I had participated in exactly 100 medical rounds. But our first weeks at home were very hard. It was beginning of RSV and flu season, and Gabriel got sick and readmitted to hospital with a respiratory infection. He was in our community hospital, and one morning while I was breastfeeding him, he started to change colors. I screamed for help and no one came. I remember our nurse's voice during the CPR course saying, "When you don't know what to do, we start CPR." I immediately put Gabriel on the crib and I started CPR. I looked around and I pressed the cold blue button. Then people came to rescue him. And 9 hours later, after a lot of advocacy, he was transferred to a children's hospital where this picture was taken in the intensive care unit. It was Christmas Eve, but as hard as it was, I was just so grateful that my baby was alive, even though we spent his first Christmas in the hospital. So this event really changed me. And that night, I made a commitment to always support the hospital Gabriel was born and to disseminate family integrated care. Because I truly believe that this mode of care should be a standard of practice. If I hadn't been involved in his care, and if I hadn't attended those education sessions that were part of the study, I would not have saved his life that day because I wouldn't know what to do. So with my heart filled with gratitude, I started to volunteer in the NICU at Mount Sinai Hospital in Toronto, where he was born. I was offering peer support while also navigating the first years at home. So this is Gabriel's care map on the first and second years of his life. This truly became our new normal. Every bubble you see here represents someone involved in his care. Specialists, therapists, early intervention workers, case managers, medical supply vendors, and more. I became the care coordinator, the scheduler, the communicator, and the person responsible for keeping everyone here on the same page. It was really overwhelming. In that second year alone, we had 187 appointments. That's more than one appointment every other day. And each time we met a new provider, I had to retell our story from the beginning, which means reliving the trauma over and over again. There was no continuity of care. There was no sharing files between providers, and no one asked how I, as a mother, was managing all of it. And Gabriel's development was delayed. I knew this could happen because he was so sick in the NICU. I had learned about education, on the education sessions about developmental delays, and I knew he wasn't reaching any milestone. But I still had hope that he would catch up. But at 20 months old, I went to a neonatal follow-up appointment. I went alone because I thought it was just going to be a regular appointment. But that day, without any warning or preparation, Gabriel was diagnosed with quadriplegia, cerebral palsy. And my world truly collapsed. I quickly learned that no matter where you are in the world, whether in Canada or in Brazil, where I am from originally, when you have a child with special needs, it requires advocacy. And that became our new normal. And now every time something happens that requires adjustment, I remember that it's just a new normal. And I have to tell you, this is so much easier to adapt and embrace the challenges, whatever situation is ahead of us. So navigating this part after discharge brought back the pillars of FiCare for me. It helped me to get through another difficult time. So when I reflect back on my journey, particularly on the impact of being involved in Gabriel's care in the NICU through this study, I realized that I became a very confident parent. I gained knowledge and many life skills. I found my voice to advocate, and I have a positive look on life despite of all our challenges because they never ended. I really learned to live in gratitude because I knew that not all babies and families would have the same opportunity I had to bring Gabriel home and be able to support him along the way. My reflection really fueled my passion for parental involvement in their baby's care, which led me to join the Family Integrated Care Steering Committee, which I'm still working with. I became an ambassador for this model of care, and I've been disseminating FiCare for the last 12 years in Canada and worldwide. And 8 years ago, I have the honor to join the Canadian Premature Babies Foundation, which is a national parent-led organization providing support and education for parents in and after their NICU stay. Our volunteers are parents of premature or sick babies or adults who were born preterm and healthcare providers. Our organization was developed on the pillars of FiCare. But you hear me talking about FiCare, what are these pillars, but what exactly is this model of care? I'm just going to give a quick glimpse of what that is. There's more information on their website. Family integrated care is one step further from family-centered care, which is the foundation of FiCare. The guiding principle is that parents are truly partners in their baby's care and should be supported to participate to the best of their ability. Therefore, they should receive psychosocial support and education. And the philosophy of FiCare is that the ideal healing environment for a baby is in the arms of their parent. And parents have a very important role in decision-making about the care of their baby. Parents should be recognized as collaborators in their baby's medical care, and parents should never be treated as visitors. Parents are never visitors. They are the parents parenting in a different environment. So this model was co-designed with parents, and they were involved in every step of the way to make this model a true success. So on a side note, I really want to show you the results of the FiCare study because I think this is very relevant to any work that will be done or is done in the community after discharge. So the study has shown the impact of FiCare on infants. They had better growth in the NICU. They had better success breastfeeding on discharge. They went home earlier. They was discharged a few days earlier. They had a better weight gain. They had better self-regulation at 18 months of age. And this is what really excites the team to see that is a long-term outcome. And they had improved motor development. But the benefits of the FiCare is not only for the babies, it's also show benefits for the parents. Parents developed hand-on skills, as I could you could see on my own story, they developed a closer emotional bond with their babies. They felt more confident and competent taking care of their baby. And parents really value the friendship and support of other parents. So those are all the benefits, and you can check on their website to see more and learn more about the study. So at CPBF, based on this philosophy, the Canadian Premature Babies Foundation developed 4 focus areas to support the implementation of FiCare across Canada. So our 4 areas are support. So we provide peer support and mental health support for families. And after COVID, everything became so much easier because we provide all those things online, virtual, so no matter where families are in the country. We also partner with experts to create educational materials that are evidence-based and are reviewed by our family advisors to make sure they are appropriated and in play language. We translate our materials into different languages because we have a very multicultural country. We certainly advocate for our families and raise awareness about prematurity, the importance of breast milk and skin-to-skin care, and certainly we advocate for parental presence in the NICU. And we've been collaborating with researchers across Canada and worldwide to bring parents' voices to projects so they are meaningful and relevant. And we do the same with quality improvement projects. We train parents what is a quality improvement, how they can initiate quality improvement projects, and present to the hospitals where they either volunteer or work. So we also have some materials in Ukrainian, thanks to Alexandra from Early Birds, who translated one of our infographics. We have a partnership with a network that creates culturally adapted materials to 10 different communities across Canada, including Ukrainian. We have a lot of families from Ukraine in our country. So these families can access the materials delivered by a physician or a healthcare provider from their own community in their own language in a way that is culturally adapted and easier to take up that information. And if you're watching us today here, you can go to our website and download anything that you want that can support your work, whether in a hospital or in the community. So now on the second part of my presentation, I will talk about where Canada is in neonatal care and neonatal follow-up and the role of our parent organization with this system. So to give you an idea about Canada, we are a country with continental dimensions. It's a very big country. We have 178 neonatal intensive care units. 31 units are level 3, and they are located in major cities, mainly in the south of the country, such as Ottawa, Toronto, Halifax, and Victoria. Families have to travel long distances to access this level of care and spend months away from home when their babies are admitted in a hospital. They also have to go back to neonatal follow-up appointments to follow the schedule of those clinics. Although virtual appointments have become an option for some families after COVID. So we have a really good telehealth that is working well for families. So we are a very diverse country with immigrants from every corner of the world, which makes very challenging sometimes for the NICUs to have interpreters and translators for families. We have about 30,000 babies born prematurely in our country every year. And we are saving babies as early as 22 weeks gestation. Well, we know this is critical that these babies receive neonatal follow-up. Canada has neonatal follow-up clinics that follow babies born less than 30 weeks or with extremely low birth weight until the age of 3, and some clinics until the age of 6. They keep track of the neurodevelopment and make necessary referrals to community services such as occupational therapy, physiotherapy, and speech and language therapists. This network is called the Canadian Neonatal Follow-Up Network, or CNFUN, and it is a voluntary collaboration between neonatal and perinatal follow-up programs in Canada and their multidisciplinary team. It was developed in liaison with the Canadian Neonatal Network, which is a network that collects data from all babies born in level 3 NICUs in Canada to really facilitate collaboration in research, integrated data collection, knowledge translation, and to improve the quality of care and long-term outcomes of children seen in their programs. The goals of this network is to establish a network of Canadian healthcare professionals involved in neonatal, perinatal follow-up programs. Is to develop a common standardized set of assessments to be done at standardized ages and common definitions to create the CNFUN dataset. Is also to develop a national electronic database of the CNFUN dataset and link it to the neonatal and perinatal datasets, including the Canadian Neonatal Network. So it's also to use the CNFUN database to improve health care and its provision by providing accurate data information for decision making, identifying best practices, and facilitating the acquisition of long-term outcomes data in neonatal and perinatal and early intervention research. And very important is to use this to advocate for our population of children by ensuring that the best evidence is translated into practice. So our organization has been collaborating with CNFUN for many years. We work together to bring parents' voices to research. You can see here there are many publications, especially around redefining outcomes that are meaningful to families. I highly recommend you check our Parents' Voice project. It's on our website. I will share the link later. There we talk about outcomes that are just as important, such as sleeping, self-regulation, feeding, and not only the traditional outcomes such as bronchopulmonary dysplasia or physical disabilities. We have presented in many conferences together, not only in Canada, but in many other countries. And we've been disseminating knowledge and advocating for implementation of best practices. We created educational materials to teach parents the importance of neonatal follow-up and what to expect in a neonatal follow-up appointment. We have a video that shows parents step by step what to see, what to expect, how to prepare for a neonatal follow-up appointment, particularly the one at 18 months. That is a very long appointment. We know that parents are anxious because many diagnoses such as autism and cerebral palsy are made during this visit. So parents go to this appointment already with a lot of anxiety, and many parents choose to, not many, but few parents choose not to go because they're afraid of receiving bad news. So we are currently working with them on early identification of cerebral palsy and developing tools for healthcare providers to communicate with families, as well as tools to help families understand what was said during appointments. And you can see the Discussing Cerebral Palsy infographic that we just launched this year is really to teach parents what that means. What did you hear on these neonatal follow-up appointments? It's extremely important to work with us parents and parent organizations to learn about how to best communicate difficult or life-altering news, such as cerebral palsy diagnosis. To this day, I remember vividly how the doctor sat down in the neonatal follow-up clinic and broke the news about my son's diagnosis. She gave me life-altering news without any warning. I was alone in a room. I didn't bring anybody with me, and I was offered absolutely no support. I remember leaving the clinic. I sat down in my car with my son on the car seat, and I just cried because I didn't know what to do, where to go, and what was next in my life. So this became my passion work. And because I really hope that no families ever feel lost and alone when they receive such diagnosis, or any diagnosis for that matter. We all know that the prematurity journey does not end when the baby gets discharged from the NICU. Many groups in Canada are working to create a support system for families during this transition period. The transition can be accompanied by a sense of loss as parents leave the familiarity of the NICU and the care team that they learn to trust and take care of their family. So transitions are very hard, especially for families living in remote or rural areas with little support, and for those babies who have complex healthcare needs. But we all know that families who experience a preterm birth and babies admission in NICUs are all at a higher risk of developing postpartum depression, anxiety, and you can see here some staggering numbers, such as almost 30% of mothers and fathers of preterm babies experience post-traumatic stress disorder. And the stressors come from infants' medical condition and appearance in the NICU because they look nothing like a baby when they are first born. The NICU environment, the alterations in our parental role. Right now, we are not a parent. How can we be a parent in that environment? We have to be involved and included in the baby's care to feel like a parent in that very stressful environment. And we also know that in Canada, we have a variation of mental health support across all our hospitals. And because we are a provincial healthcare system, each province always also have different programs, which is very hard to have something combined in the entire country. So I will share with you, this is a very busy slide and apologize for that. This is a pilot study of the FiCare home, which is the continuation of the FiCare model for the transition to home. The FiCare team looked at the evidence showing that the negative psychosocial effects of the NICU can persist in parents more than 2 years after birth. So the long-term effects, including respiratory illnesses, neurocognitive and behavior delays, have been shown to cause both financial and psychosocial impact on quality of life of infants and their families. So with this data in hand, the FiCare team co-designed a pilot with parents. The goal was to learn if by providing multifaceted hospital and community-based support and education at discharge helps to mitigate the risk of long-term adverse outcomes in the babies and in their families. And supported here included connection with other parents, peer-to-peer support, and guidance to bridge the gap between the NICU and home care. So families of babies born less than 34 weeks gestation were recruited while they were still in the NICU. And then they were referred to community public health nurse and peer support group in their region. Families attend education sessions in hospital to prepare for discharge. And they were given a binder with post-discharge resources, such as information on how to introduce solids to your baby, about language development, baby massage, things that they could do at home with their baby to really support their development. So there was a graduate NICU parent who co-facilitated the education sessions in the hospital and the community. And once the families were discharged, they had a public health nurse visit at home, and they also attended the community support groups. The study assessed the potential of empowering parents with peer support and other resources to help them feel more confident in caring and advocate for their babies post-discharge. The FiCare home study, the pilot has just finished the pilot phase, and the results should be published very soon. So there is more information on the website, which is familyintegratedcare.com. It's all in English, but I'm sure these days we can all translate the information on those websites. So another interesting project that I want to share with you is the CSENT project, with this coached, coordinate, enhanced neonatal transition with the goal to support parents during the transition to NICU to home and throughout the first year of life. The focus was on parents who might take on a medical caregiving role for their child at home. Their babies might be followed by multiple specialists, as well as neonatal follow-up program focusing on neurodevelopmental outcomes. This group knew that psychosocial support for parents is also limited. So this research group looks at the parental mental health in relation to infant development, because we know the evidence has shown that enhanced psychosocial support for parents decreases stress, anxiety, and depression. And in terms, this improves parent-infant attachment and developmental outcomes for preterm babies. So families and healthcare providers have identified the tools to address a family's medical and social needs must extend beyond an ICU to include the transition home and the first year of life. So this was delivered by a nurse navigator who provided support for 12 months in 3 different ways. First was the anticipatory education, meaning proactive education targeting typical challenges caring for high-risk babies' healthcare and their developmental needs. There was coaching and psychosocial support through 5 sessions in person and follow-ups weekly or monthly, informed by an intervention called ACT, which is Acceptance Commitment Therapy. ACT, just a quick note on ACT, is a behavior therapy involving acceptance, mindfulness, and behavior change strategies. ACT encourages people to embrace their difficult thoughts and feelings rather than avoiding them, and choose actions that align with their values. It has shown to reduce maternal depression and can be delivered by a range of training facilitators, which is the great plus on this intervention. And he also focused relationship building, medical and social problem solving, and the navigation with community resources post-discharge, because navigating our healthcare system in the province where I live in Ontario, it's very hard because there is no seamless communication between centers. So the primary goal was to evaluate the impact of CSENT intervention on parents' stress at 12 months of age. The criteria to participate in this study was parents of babies born less than 26 weeks gestation, or between 27 to 29 weeks if they presented 1 or more risk factors such as necrotizing enterocolitis or retinopathy of prematurity. and some other conditions. In other words, babies who had complex care needs. So there was incredible qualitative data collected from this study, and all the comments were all positive, and we could clearly see the impact on families. This mom said what is really awesome is having somebody who clearly understands what your experience is like. They responded to your feelings and worries in a completely supportive way. Because the outside world does not understand this experience. And the way people respond is so stressful and so unhelpful. The quantitative study was a little bit of a surprise because the primary outcome of parenting stress at 12 months at age was not significantly different between the intervention and the control groups. So there are several possible reasons why this happened, one being not having a standardized tool to measure, and they are doing now an ongoing analysis to explore the secondary measures. So where we are right now with this study, we are entering phase 2, which is exploring barriers and enablers to the implementation of CSENT from the perspective of parents and healthcare professionals. The objective is to assessing and developing an adapted navigator role to support parents during this neonatal transition. We are investigating whether a graduate parent, somebody like me, would be a suitable navigator to take on this role, certainly with the proper training. So before I wrap up my presentation, I would like to emphasize that the NICU is just the beginning, is one chapter. What happens after discharge is equally important. Babies need ongoing monitoring to support their development and long-term health. Families need guidance, emotional support, and community connections. We must bridge the gap between hospital and home. We have to ensure that every family feels prepared, supported, and never alone. We must all commit to strengthening neonatal follow-up programs and transition care services across all communities so every baby can thrive and every family can heal and grow with confidence. And no one can really do this alone. Parent organizations are essential allies in neonatal care. In these photos, you can see healthcare providers working side by side with us parents to advance practice. We bring lived experience, trust, and community connections. Our work complements healthcare teams, ensuring care is not only clinically effective, but also emotionally responsive. When healthcare professionals and parent organizations work together, care becomes truly integrated from the NICU to home and beyond. We still have a lot of work to do, but this quote says that alone we can do so little, and together we can do so much. And together as parents, professionals, and communities, we are building a world where every baby born preterm has the chance not only to survive, but to thrive. So to these incredible healthcare teams working in Ukraine, thank you. Thank you for your courage, your compassion, and your commitment to caring for the tiniest and most vulnerable, even in the most unimaginable circumstances. You continue to show up for babies and families every day, despite the challenges. And today you took time to learn, to share, and to connect, which is a true reflection of your dedication to improving care, even during crisis. So your resilience truly inspires us, your strength really humble us, and your humility unite us. And from all of us, from the Canadian Premature Babies Foundation, we stand with you. Thank you. I'm happy to answer any of your questions.
I can see that there are words of gratitude to you and the expression of the gratitude for your personal story, and people are commenting on how strong you are and what a spirit you have, and that this is very impressive. There are two comments which probably I would like you to respond, not even as a question, but as a comment. The first comment is that before, in the 80s and 90s, there was an obligatory attendance of the pediatrician and the nurse to home of the newborn babies, including those who were born with low weight. So how is it in Canada now? Is it usually that parents would take the baby to the hospital, or is there attendance at home, whether for the babies who were born healthy or for the babies who were born with the low weight?
This after discharge you're talking about, right? Because your audio is cutting off a little bit.
Mm-hmm.
Yes, so for term babies, so Canada has a provincial healthcare system, and each province has different programs. In Ontario, when you deliver a healthy baby and you go, you have your baby in the hospital, you come home, on the day 3, you receive a call from a public health nurse, and she makes an assessment over the phone, how the parent is doing, if any resources is needed, and then she can make referrals, or she can make a home call if a family is perhaps in crisis, doesn't have support, of babies struggling to latch, or having some issues gaining weight. It's recommended that families go to see a family doctor or a pediatrician a week after discharge. For premature babies or babies with premature babies, at discharge, you have to have an appointment with your community healthcare worker on day 3 of life. Family will still receive a call from public health, but families will be followed close by the family pediatrician or the family healthcare provider. Babies who are born less than 30 weeks gestation in Canada, they are the ones who qualify to go to neonatal follow-up clinic, which is for neurodevelopmental assessments, not for health assessments, if I answered the question properly, Katya.
Да, дуже добре Фабіана відповіла на це питання. І в мене є наступні ще питання. Зараз в своїй роботі як розподіляються ролі, чого ви очікуєте від держави, чого очікуєте від менеджерів, наприклад, лікарень, і чого очікуєте від батьків? Які у вас є плани на цих 3 великих гравців?
For government, always more funding, for sure. We always advocating for more funding to hospitals. Our hospitals are, they receive provincial funding, and many hospitals certainly do their own fundraisings for equipment. But this is the system, healthcare system itself. Hospitals itself, for our perspective as a parent organization, we advocate fiercely for parents to be involved in the care of their babies, because we know the long-term impact of parents not being by the bedside, not being involved in their baby's care. We know that skin to skin, it is a medical intervention, not a nice thing to do. It is a medical intervention that saves lives and has long-term positive impacts on the life of those babies. So this is a big advocacy from groups in Canada, many groups, including ours. We work with a lot of networks of healthcare providers who share the same philosophy to make sure there is this model of care in every hospital where parents are not considered visitors, but are an integral part of medical care teams. On the family perspective, we try the best of our ability to empower parents to be by the bedside, to advocate for their babies in the community. We know parents come from many different walks of life. Not all parents will become a big voice, a big advocate like I become. I hear this many times. Not all parents will be an advocate like me, which is understandable. But we want every parent has the right to know what's happening to their child. Every parent has the right to be by the bedside, take care of their children, and access care in the community. So we are very fortunate that in Canada, we do have a public healthcare system. So everybody has access to care. But we still have inequities in care for families who don't live in the big cities and live long distance. We have a very big indigenous communities living in northern of Canada, and they don't have the same access to neonatal follow-up or to intervention for their babies like babies born in big cities, in big centers have. So there is a lot of work that we need to do. That's why we need more funding from the government. We need more education for the families, and we need to shift the mindset of healthcare providers that parents are parents, and they should be seen and treated as parents in hospital for a better transition home and long-term outcomes for the babies.
Мені дуже сподобалось в вашій презентації, коли ви сказали, що батьки – це не відвідувачі, що батьки – це батьки, які працюють батьками в лікарні. Як ви змінюєте цю культуру? Як саме ви працюєте з медичними працівниками? І що складно, а що легко дається?
Wow, thank you for this question, because this is my absolutely passion work. If I leave nothing behind, this is one thing that I want to at least plant a seed of change. So Canada was doing well before COVID. Many units in Canada were moving towards family integrated care, meaning parents had access to their babies 24/7. Parents were involved in their babies' care. Parents were receiving education, and parents were receiving peer support. When COVID happened, all the restrictions, like in every hospital around the world, were imposed on families. Policies were changed without consultation, and parents were had restricted access to their babies. As you know, because I know Ukraine also had the same issues, because we all work together, parent organizations from around the world, to change those policies. We have not gone back to where we were prior to COVID. So what we have done as a parent organization working with hospitals, first we did a study called the Presence Study. And this study, we did a systematic review on harms versus benefits of having parents in the NICUs. We came up, it was a multidisciplinary team, and we worked with over 30 healthcare providers and families to come up with 13 recommendations on parental presence. The goal is that hospitals change their policies on parental presence. We have a different paragraph when they said, this is visitors' policy for hospitals visits. This is parents' policy to come to the hospital and parent their baby in our units. So this is the goal of this presence study, which I'm very happy to share. There will be a toolkit for implementation of these recommendations coming up this year, end of this year. It will be easier for hospitals to implement the recommendations. And the recommendations, for example, is uninterrupted access to your baby. You have access to your baby 24/7. You have access to skin, provision of breast milk, mental health support. This is the kind of recommendations. We did a study in the context of the pandemic, but the recommendations apply to any unit and any time, especially in adult hospitals that have neonatal intensive care units. They don't see parents as parents. It's a different approach than pediatric hospitals. So it has to be a change in the mentality the philosophy and a culture shift on the healthcare teams, starting from leadership. Nothing changed. The leadership doesn't have the same philosophy. So in Canada, we have what I mentioned during my presentation, the Canadian Neonatal Network. This network is 31 level 3 NICUs across Canada working together to improve outcomes of our babies born less than 30 weeks admitted in those units. As part of that group, lives CN Fund, the Canadian Neonatal Follow-Up Network, collecting data to show this group that outcomes have been improved because of quality improvement projects. We launched this year, which is a historical moment for Canada, the Family Engagement Working Group. The Family Engagement Working Group is going to measure outcomes on babies based on parental engagement. We want to show, using quality improvement projects, that our engagement in the NICU will have an impact on the babies. Our first variable that will be measured is skin to skin. We chose skin to skin because it's a low-hanging fruit. There's a lot of evidence on skin to skin. We don't have to reinvent evidence. It's already there. We want to measure that so that we can show with the data, because data changes practice. We have the data, we advocate with the data, and we're gonna hopefully in a couple of years from now have enough evidence to show, okay, this is a life-changing intervention. We need to keep doing this. So this is our very first working group doing that, and we are currently receiving protocols from NICUs across Canada, their protocol on skin to skin. And I can tell you, just doing this work for 5 months, there's a huge variation in our NICUs related to skin. Some NICUs don't let parents hold the babies for the first 72 hours of life because of the golden hour. Hence, there is no strong evidence proving that. Some NICUs don't have protocols for skin to skin, so it is a lot of work to do. And what we do as a parent organization, we continue to create social media campaigns. We continue to present in conferences. We continue to present in hospitals. We do lunch and learns to really show healthcare providers the importance of having us by the bedside. We are not competing with the nurse. We are there to parent, and the nurses still have their jobs doing what they do best, but coaching us how to parent in that environment.
Ще таке питання. Ви сказали, що доступ нерівний. І, наприклад, не у всіх однакові можливості, і хтось живе дуже далеко. Яка допомога надається таким батькам, наприклад, щоб доїхати кудись до госпіталя? І хто надає цю допомогу? Якщо вони, наприклад, бідні, і якщо вони живуть далеко і не мають машини, до прикладу.
Oh, that is a great question. For indigenous families who live in remote communities, there is a full support for the families to move into the city for the time being. So they have access to, there's a lot of communities in northern Canada that they don't have road access. So we call the fly-in communities. So government provides the transportation for the families coming to the city. Okay, and the families either stay at Ronald McDonald's house. I don't know if you have a Ronald McDonald's house in Ukraine near hospitals. So that is a facility. Other families, they do have to pay out of pocket to stay in hotels near hospitals. And hotels provide discount for families who are in, for example, in a pediatric hospital for an extended period of time, but they don't live far enough to be able to access a Ronald McDonald's house. If a family is very poor and cannot, I mean, we don't have families live under the poverty line in Canada, but there are poor families. Let's not kid ourselves. We are in a very developed, rich country, but we have a lot of social issues. Families can talk to social workers in the hospitals and let them know their financial situation. There is assistance to families, whether it's through the hospital or to charities that provide funding for families or gift cards to buy food or transportation. But it is not an equal system. It is an equal system to receive care. It's not an equal system that everybody has somewhat the same financial situation, if that makes sense.
І ще таке питання. Ви сказали про права батьків. Ви декілька разів говорили права батьків. Наприклад, якщо батьки бачать, що їх права в шпиталі порушуються, що вони можуть робити? До кого вони можуть звертатись? Хто буде їх адвокатом в цій ситуації?
That is a very good question. So from my experience working in this organization for 8 years, what I've seen, that a lot of parents don't actually know their rights to build their babies. Okay, and especially during COVID, we saw this very, very clear that families did not went themselves to advocate to be with their babies. They needed an external support, such as our organization or a nurse who was a champion for families in their hospital. And from my experience, what I noticed is because families are afraid in many circumstances, not all families, but many families are afraid that if they say something, we will somehow damage the care their babies receive in their unit. Okay, but other families who have a more an advocate approach, or they are more outgoing, they can talk to a nurse leader from any NICU and say, I feel that I should be doing this and I'm not doing this. I feel that our teams in the hospitals are very open. We have great leadership nurses and professionals in the NICUs that we don't have this violation of human rights in the unit. I think the right, when I mention, is like we have the right to be with our baby, and not all hospitals are providing that opportunity for parents. And parents might not know, because it's okay, I'm going to respect this policy that I can only be there from 9 to 8 at night and not 7. But I say that all the big level 3 NICUs in Canada today, all parents have a 24/7 access. Our advocacy is still on smaller hospitals who are usually adult hospital with a small unit where they don't have the same philosophy, the same understanding of the importance of parents being there with their baby. But the level 3 NICUs, parents have 24/7 access. They might not be super involved in the care of the baby. This is our still ongoing advocacy, but they are in the unit.
І ще таке питання від наших глядачів, від пані Альони Балакової. Скажіть, як держава фінансово захищає Інститут материнства і дитинства? Чи є якась державна програма? Чи є якісь виплати, наприклад, батькам?
I think you mentioned like maybe parental leave. So in Canada, we have what we call parental leave. It is federal, it comes from the federal government. Parents have regularly 1 year parental leave with a possibility to extend it to another 6 months. This is for every parent who has a full-time job that can access parental leave. It can be split between the mother and the father, or if there's 2 mothers, can be split between the 2 mothers. For babies who are admitted in NICUs, this is a big advocacy that our organization did when they first started 12 years ago, to have an extension of the parental leave, meaning the parental leave is starting to be counted from the time the baby gets discharged to home. So the period the parent is in the NICU with the baby they start receiving the parental leave, but the days off, they start counting from the day the baby gets discharged, which is very important because that allows parents to be in the hospital. For example, United States they don't have parental leave. So you see a lot of families going back to work 2 weeks after giving birth and having extreme premature baby in the hospital. So they have to be at work, pumping, they cannot be at the bedside. It is a huge problem in the United States. And we are very grateful that we don't have that in Canada.
Дуже дякуємо Фабіані за таку презентацію і, я б сказала, за пристрасне відношення до дітей, які народились з низькою вагою, і за пристрасне відношення до прав батьків. І сподіваємося, що це наша не остання зустріч. Я бачу, що було дуже багато людей на Zoom, більше ніж 200. І ми всім вам дуже дякуємо, що ви виділили час для того, щоб бути з нами в прямому ефірі. Запис також буде доступний і в англійській версії, і з перекладом. Тому поширюйте серед колег, які не змогли бути з нами сьогодні в онлайні, щоб вони могли подивитись цей вебінар потім. Дуже дякуємо, Фабіана, ще раз. І всім бажаю, наскільки це можливо, тихого вечора сьогодні. Дякую.
Thank you.